Good afternoon, everybody. Thanks for coming in this week's installment of Grand Rounds. Make sure you grab an evaluation sheet as you walk in and sign the attendance record so you can get your CME credit. It's my pleasure to introduce Dr. Wickemeyer, cardiologist with Iowa Heart Center in Des Moines. Dr. Wickemeyer is going to speak to us today about kind of the current state of the art in managing patients with advanced heart failure. And I did notice in his CV that he is recently board certified in advanced heart failure and transplant cardiology. So looking forward to hearing his thoughts on this important topic. Please help me introduce or welcome Dr. Wickemeyer.
Thank you. Thank you. Does this work okay? I think you can probably hear me. Well, I want to thank the organizers for the opportunity to let me come talk to you about heart failure, which is something I've been interested in for 30 years. I've been practicing in Des Moines for about 33 years now, and many of those years I've had a special interest and focus on congestive heart failure, and I've come to have extreme respect for this very complex syndrome. Just when you think you understand it, you realize that it's so complex that you don't know it nearly as well as you think you do. I'm old enough to remember being taught that beta blockers were contraindicated in heart failure. These are negative inotropic drugs. You shouldn't be giving them to patients with heart failure. And of course now they're the mainstay of our treatment of heart failure. And so there are so many things like that that have abruptly changed direction as we learn more and more about this complex syndrome. And it's hard to decide how to limit your talk on heart failure to 1 hour. What I'm going to try to do is talk about advanced heart failure, this incredible technology that's developing of left ventricular assist device therapy, how this applies to Iowa, and then some of the more practical recent developments in heart failure. So with that, let's look at the demographics of heart failure mortality. Here we go. So here we are in Iowa, and the more red, the more mortality, and the more white, the less mortality. So in Iowa, we're doing a pretty good job. We're kind of this island in the middle of all this red, and right in the middle here is Ames, white. So you guys are doing a great job in your heart failure mortality. And one question I have is, what's going on down here? How can Florida have such low heart failure mortality? I've got to look in to see what they're doing, or perhaps it's a reporting issue. With all the aged people in Florida, I find that hard to believe. But in any case, we have 6 million adults, or 2.4% of the population. By 2030, 8 million adults. Primary cause of death, 55,000 a year. Contributes to 1 of every 9 deaths. And heart failure has a 50% mortality within 5 years. Now that's a high mortality, and I'm going to talk about that a little later when I talk about palliative care, but you know, that's higher than a lot of cancer mortality, and we really don't focus on that. So we have divided heart failure into stages and classes. The stages of heart failure are represented here. Stage A is just risk for heart failure, hypertension, coronary disease, diabetes, but no left ventricular dysfunction, but risk for left ventricular dysfunction. And we know that in our society this is going up with obesity and diabetes. So heart failure is projected to be a growth business, unfortunately, in the coming years. And the importance of focusing on heart failure as a subspecialty within cardiology is growing. We recently came up with the separate boards for heart failure within cardiology. So this is well recognized as a unfortunate growth industry. Stage B is asymptomatic left ventricular dysfunction. So someone has a reduced ejection fraction for whatever reason, but they're not yet symptomatic. We call that stage B. Stage C is where most of our heart failure patients live. These are patients who have become symptomatic because of their heart failure or have been symptomatic in the past. And finally, stage D, which I'm going to focus on today, these are the end-stage patients, class 4 patients who have a short time to live and have a lot of symptoms. And it's estimated that about 10% of the stage C plus D patients, so all the symptomatic patients with heart failure, about 10% of them are in stage D. So this slide just, again, differentiates between the classes and the stages of heart failure. So here are the stages I just mentioned, A, B, C, and D. And since you're not symptomatic till you're in stage C, the functional classes of heart failure that we're used to, New York Heart Association functional class 1 through 4, represent the difference in symptoms in stage C and D of heart failure. Class 4 is generally a stage D symptom, and classes 1 through 3 are stage C of heart failure, just so we all are know what we're talking about. And then finally, in the advanced heart failure world, we have sliced it up even more with the INTERMACS registry. INTERMACS stands for Interagency Registry for Mechanically Assisted Circulatory Support. It was a registry that was started when left ventricular assist devices began to be developed, so we could track the success or failure of left ventricular assist devices. They were all entered into this INTERMACS registry. And this INTERMACS profile became the way we talk about advanced heart failure patients. And so what they've done is divide stage D or class 4 heart failure into 7 segments, which is somewhat overkill in my opinion, but this is the way it's been done. So class 1, INTERMACS 1 is a patient crashing and burning, going into shock, has a few hours to live. INTERMACS 2 is a patient on inotropes that's going downhill, and you have days probably to do something or they're going to die. Stage 3 are patients that are stable, but they're inotrope dependent. Stage 4 are patients with resting symptoms just short of inotrope dependency. 5, 6, and 7 are various gradations of slightly less severity of illness. So when we're talking about advanced heart failure, we say is an INTERMACS 3 or an INTERMACS 4. Everyone understands what we're talking about, and so it makes it a lot easier to communicate about these patients. And we do a lot of communication because there's a lot of intra-institutional discussion and transfer of these patients because they can be so ill, they need to be considered for advanced therapies that are just available in certain spots. So how do we identify patients with advanced heart failure? Well, repeated hospitalizations, patients who can't stay out of the hospital. Progressive deterioration in renal function. Sorry, that should be deterioration in renal function. Rise in BO and creatinine. Weight loss without other cause, in other words, cardiac cachexia. Intolerance to ACE inhibitors due to hypotension and worsening heart failure or hypotension. Now, this is a big one. And so we all see these patients with heart failure that are getting hypotensive, their renal function is deteriorating, we have to take them off ACE inhibitors. That's a big red flag. When a patient has to come off an ACE inhibitor because their heart failure is so bad, they are getting severely ill and need some discussion about the next stage of therapy. And that next stage may be palliative care, or it may be consideration for assist device or transplant. Frequent episodes of hypotension or constant hypotension, persistent dyspnea with daily activities, inability to walk a block. Frequent ICD shocks. We see this, patients with ICDs and LV dysfunction, and we just can't keep them from getting shocked. They're getting to the end, and we're going to have to come up with some plan for them. Increasing need for diuretics and progressive decline in serum sodium, so that they're so volume intravascularly depleted that their antidiuretic hormone is turned on and they're retaining free water to preserve cardiac output at the expense of their tonicity. So these are all signs of advanced heart failure. And we know this is a progressive disease. Eventually patients stop responding to medical management. Stage 1, risk factor modification, ACE inhibitors and ARB. Stage 2, we add beta blockers, although make a case for adding them earlier. Stage 3, diuretics, digoxin, aldosterone. Nasiratide we don't use much anymore. CRT, this is cardiac resynchronization therapy, putting in that third lead to resynchronize cardiac contraction. Can be huge. I've seen a number of patients go from class 4 to class 2 just by adding that extra lead and resynchronizing the left ventricle. So we always do that if it's a possibility. But then finally, in stage 4, we're about at the end. Hospice is a consideration, palliative inotropes, or ventricular assist device, bridge to transplant, destination therapy, or transplant. So this is the progression that we currently see over and over. So transplant is an option. So how realistic is transplant for most patients? This is a graph from the heart failure registry around the world, and it shows all the transplants done in the world. In green is the United States, in yellow is Europe, in red is all the other countries. As you can see, over the past decade, in the United States, the number of transplants has been remarkably constant at about 2,400. Around the world, about 3,600. This has not changed, and this is totally because of the limited number of donors. This is totally donor-related. We just don't have enough donors, and in fact, the donors we're getting are getting less and less good as donors because, you know, people are wearing helmets, wearing their seat belts, and so we're having less and less of the young, brain-dead donors and more of the older donors that are not quite as good candidates, but still able to be donors. So transplant is an option for some patients, but it's very limited. And how does this relate to Iowa? Well, we've got 3 million people in Iowa, which is about 1% of the national population. And if we remember, about 2.4% of the entire population has symptomatic heart failure, stage C and D. So that's about 72,000 of patients in Iowa have symptomatic heart failure, and 10% of those are stage D, so we have about 7,200 stage D patients in heart failure, rough estimate. And then remember, there's about 2,300 donors available in this country. Our share of that is 1%, since we're 1% of the population. So our share of the donor pool is about 22 heart transplants. So in Iowa, we have about 22 heart transplants for 7,200 patients with stage D heart failure. So drop in the bucket. So do Iowans have appropriate access to heart transplantation? Well, again, we have about our share of the donor pools, about 22 transplants per year. The number of Iowans that go out of state for transplant is looked at in this graph. So it's about 10 a year go out of state. And at the University of Iowa, where we do our heart transplants in state, they do anywhere from 10 to 15 a year. So that adds up to about 25 a year. So actually we're doing a pretty good job given our allocation of hearts to get Iowans heart transplants. So we're not doing too badly there. So what about mechanical circulatory support? Well, if we do the math here, I won't go through all this, but it's estimated that there's about 3.7 million patients with advanced heart failure in the United States. Now, we're going to exclude 3/4 of them from mechanical assist support because of various comorbidities. They have renal failure, they have advanced lung disease, they have poor social support, they use drugs, whatever. But so we're going to just say only 1/4 of the advanced heart failure patients are candidates for mechanical support. So that brings us down to about 93,600 patients in the country, which equals 30 patients per every 100,000 population. So on a national level, a very conservative estimate is that for every 100,000 people, there's about 30 potential candidates for left ventricular assist device therapy. So in Iowa, if we look at our population of 3 million and we look at this equation, that comes to about 915 Iowans should be candidates for left ventricular assist device. And, you know, we're not even close to that. We're maybe 10% of that. Excuse me. So we're not doing as well with mechanical support in Iowa. So when we were presented with this data, we decided that in Des Moines it would be worth considering moving into this area. So we are starting a left ventricular assist device program. Now this is the rise of the LVAD. This is the study called the REMATCH trial that put left ventricular assist device therapy on the map. This was a study comparing the HeartMate 1 with medical therapy. And so you can see here the patients with Class D heart failure on medical therapy had a pretty miserable survival curve. And those with the HeartMate left ventricular assist device did much better. But at the end of 2 years, they were all dead. So when we were presented with this 10 years ago, we thought, you know, this doesn't look like it's ready for prime time or ready for us to take the step to get involved. So then the HeartMate 2, which was a revolutionary device, was developed. And again, this is the graph I just showed you with the HeartMate 1 versus medical therapy. And then they compared the HeartMate 2 with the HeartMate 1. And you can see there was a dramatic improvement in survival. This curve practically is superimposable on this curve. This is the HeartMate 1 in 2 different trials. And this is now the HeartMate 2, the advanced therapy. Much better. And at 2 years, there was 60% survival, so much better. And the difference is this. The HeartMate 1 was a pulsatile flow device. HeartMate 2 is a continuous flow device. And this was the engineering coup that allowed this technology to really take off, and I'll go into that a little bit more. So as a result of the HeartMate 2 study that I just showed you, the guidelines for treatment were changed, and consideration of an LVAD as permanent or destination therapy is reasonable in highly selected patients with refractory end-stage heart failure and a 1-year mortality of greater than 50%. So suddenly now destination therapy became realistic, which means patients who have end-stage heart disease, not transplant candidates, can be considered candidates for left ventricular assist device therapy as their final treatment. They're going to die with their device in because that's their final therapy. And as time has gone on, the survival with these assist devices has gotten even better. This is a series of studies using the HeartMate 2, the continuous flow device. And these are early trials and trials in subsequent years, so that as time goes on, we've learned more and more how to treat these patients, how to prevent complications. And so now, the 1-year survival is almost 90%, which is equal to 1-year survival with a transplant. So now this has gotten to the point where we can put one of these devices in and tell patients that their 1-year survival is equal to if they just had a transplant. And in fact, there's now a growing population of young people who have these left ventricular assist devices, and they're doing so well, they don't want a transplant. And the reason is, you know, even in the best of hands, the survival with transplant is about 50% at 10 years. So if you have a transplant, there's about a 50% chance you're going to be alive at 10 years, and the survival with these left ventricular assist devices is getting so good that many young people say, well, I want to just keep going with this assist device, and then I'll have my transplant later and prolong my life as much as possible. So that is starting to be a real issue. This is another series of survival curves looking at left ventricular assist device implantation based on intermax profile. So that if you are an intermax 1, meaning crashing and burning, about to die of shock, your survival is represented by this red. And if you're an intermax 4, 5, and 6, meaning you're the walking wounded but stable, your survival is represented by this purple line. So it's better. So it makes, intuitive sense that if you do this to patients that aren't quite so sick, they're going to survive better. And in fact, that's what it looks like here. So as a result, there's a movement to put these devices in earlier. So how do these patients feel after they have their device implanted? Well, this looks at functional capacity. This is in a group of patients that are bridged to transplant. This is a group of patients that are destination therapy. And so all of them are New York Heart Association Class 4 in red. Class 1 is in green, 2 is in blue, 3 is in yellow. So as time goes on, more and more of these patients become Class 4 after implant of the device to Class 1, and over 80% are Class 1 or 2. And it is sustainable over time in this destination therapy group. This persisted over time. They got better and stayed better, and only a very small amount are still in Class 4. So these patients get much better and stay better over a period of time. So when should we start talking about putting this device into patients? Right now, we wait till they're at end of life, and our Medicare guidelines require that. I'll go into the indications in a minute, but right now, Medicare won't pay for a left ventricular assist device unless the patients are, at near end of life. But we've seen from the survival curves that can compromise long-term survival. So there's more and more discussion about waiting or moving the device discussion with patients earlier instead of waiting till they're end stage. And so this trial is now just getting underway. It's called the Revive It Heart Failure Trial. It stands for Randomized Evaluation of VAD Intervention Before Inotropic Therapy. So what this trial intends to do is randomize 100 patients in big implanting centers that have a lot of experience with this. And instead of waiting till a patient's about to die, they're going to put it in Class 3 patients with ejection fraction less than 35. And the endpoint is going to be survival and freedom from stroke, because stroke is still a potential complication of VAD therapy. And the concept is that earlier use of VAD technology will result in better outcomes. So that trial is underway, and we're anxiously awaiting the results. So the approved mechanical circulatory support indications include bridge to recovery, meaning we have a patient who's got a very sick heart. We think their heart might get better, so we're going to use this technology to keep them alive long enough for the heart to recover. Bridge to transplant. The heart's beyond recovery, and we're going to put in a transplant, but we got to keep them alive till we get a heart for them. And then destination therapy, which is a patient who is end stage, not a candidate for a heart transplant, and we're going to keep them alive permanently or as long as they can live with this. Now, bridge to recovery has not been carefully looked at all. And the reason is, once a patient is so sick, we put in this device, our focus now is just keeping them alive on the device. There's very little attempt to maximize medical therapy, improve heart function, and get the device out. So with that in mind, there is a trial being developed now called RESTAGE heart failure, which stands for remission from stage D heart failure. So the idea is the focus of the trial is to see if this device can be used to make patients' hearts better over time. So 40 patients with ejection fraction less than 25, non-ischemic. They're going to have their LVAD inserted as a strategy of bridge to recovery. It's not a double-blind trial or anything. It's just a trial of patients with non-ischemic cardiomyopathy with a focus on getting the device out. What percentage of patients can we get the device out? Now, what was interesting to me is the medical regimen they decided to use on these patients to get the device out. They're going to give them lisinopril 40 milligrams a day, carvedilol 25 3 times a day, spironolactone 25 milligrams daily, digoxin 0.125, and losartan 150 milligrams daily. Very aggressive regimen. More aggressive than we typically use for our sickest heart failure patients. But presumably these patients will tolerate it because they've got a good cardiac output. When we try to give our sick heart failure patients this kind of regimen to make them better, they're too sick to tolerate this. But if you've got a pump in that's giving you a normal cardiac output, and patients can tolerate this kind of aggressive regimen, maybe their hearts will get better. And so that's the presumption and hope. And so the goal of the therapy will be percent of explanted LVADs at 18 months. Now, this is the device. I'm just going to go over it quickly. It's a remarkable piece of engineering. And in my mind, it's analogous to the idea of man trying to figure out how to fly. You know, when we first tried to figure out how to fly, we thought we had to flap our wings like the birds did, and so all the initial attempts at flight were movable wing aircraft that obviously didn't work. And then the idea of fixed wing aircraft developed, something that doesn't exist in nature, and that took off and allowed man to fly. And so when man started developing heart pumps or artificial hearts, we thought it had to pump. And so we developed all these pumps that move blood around the body, but these had tremendous problems that I won't go into until it was thought, well, let's just have a simple pump that's not pulsatile but just moves blood, see how that works. And after a lot of animal studies that showed it worked pretty well, it was developed for humans, and this really allowed the technology to take off. It's very simple. The pump is just an electric motor with an impeller in there that spins. You put one end of this into the left ventricular apex. It sucks blood out and puts it into the aorta. There's a drive line that provides power to this thing that exits the abdomen here. And then it's hooked up to a little computer that receives input from 2 batteries. So the energy is modulated by this computer, fed to the pump that pumps the blood. And that's, you know, really an amazingly simple but elegant device. If you look inside the device, this is the spinning rotor, and there's only one moving part, this spinner here, and the 2 bearings are made out of ruby bearings, and so this thing should last forever. It's just an electric motor with wiring here that allows it to spin on ruby bearings that should never wear out, and so this device conceivably could go on forever. Now the HeartMate 3 that's being developed has no points of friction. It's a magnetically levitated impeller, so that it just floats in a magnetic field and spins, so there's not even bearings to wear out. Now that hasn't been used in humans yet, but it's testing very well in animals. It's even smaller than this, and should, because there's no connections here that can develop blood clots, be even less prone to complications, but we'll see. But right now, this is the state of the art. And if we look at how well it's doing, there's over 6,500 patients on the device, and there are 11 patients that have had the device in over 8 years, 25 over 7 years, 124 over 6 years, so it seems to be potentially very durable. So what are the indications for durable mechanical support? Well, right now, you have to have an ejection fraction less than 25, frequent hospitalizations for heart failure, intolerance to neurohormonal antagonists, end organ dysfunction due to low cardiac output, CRT non-responder, inotrope dependent and a peak VO2 on a cardiopulmonary stress test of less than 14 cc's per kilogram per minute. So you have to be pretty sick to get a device right now. Contraindications include irreversible other organ disease, hepatic disease, renal disease, neurologic disease, severe psychosocial limitations, which often turns out to be our biggest barrier. This group of patients with end-stage heart disease seem to have an unusual incidence of psychosocial problems. Age right now, age of over 80 is a relative contraindication. Obesity or malnutrition, and you can read the list. So again, of the patients with stage D advanced heart failure, we're only going to consider about 1/4 of them to be realistic candidates for VAD therapy because of all these reasons. Adverse events, bleeding is a big one. To keep the pump from clotting, we have to give them warfarin and aspirin. And for some reason, patients with this kind of continuous flow physiology developed AV malformations in the gut that can bleed. Very similar to aortic stenosis. Those of you who have patients with severe aortic stenosis know that they develop these AV malformations in the gut that can lead to GI bleeding. And this kind of physiology seems to do the same thing. And the pump tends to chew up von Willebrand factor, which is a big molecule and gets chewed up by this rapidly spinning rotor. So bleeding is from all those reasons. They're anticoagulated, they get these AV malformations, and they get a von Willebrand type deficiency. So bleeding is a big issue. Infection is getting a lot better. Infection used to be where the drive line came out of the abdomen. And through some techniques of surgical implantation, that's been minimized, and now we're seeing much less infection. In the past, that infection would go right up the drive line into the device, and it's a mess. You have to take out the whole device and usually lose the patient. But that's gotten a lot better. Right-sided heart failure continues to be a big issue because we're giving the left ventricle a normal output, but the right ventricle isn't getting any help. So if the right ventricle is compromised, as they often are, and it can't keep up with this rocket in the left ventricle, then you get right-sided heart failure. And so we have to evaluate patients' right ventricles very carefully. And in fact, you know, we did a lot of heart transplants 15 years ago, and I took care of a lot of those patients. And they were much easier to take care of than these VAD patients, because when you do a heart transplant, you give them 2 good ventricles. But when you try to give a patient 1 good ventricle and they still have a bad right ventricle, they can be very hard to take care of. And then finally, stroke. There are various places where clots can form in the pump or in the output cannula where it goes into the aorta, and if these go to the brain, obviously they can cause a stroke, or we can see hemorrhagic strokes because these patients are heavily anticoagulated. So these are the complications that we have to deal with. Optimal timing is an art. If we find a patient that we think is a candidate, and I should mention that all these implantations of VAD devices are elective. We don't do these as an emergency. We have other ways of keeping people alive on pumps as an emergency, but an LVAD is an elective procedure. So we stabilize patients however we can, however we need to, and then we put in an LVAD electively. And so it's an art to try to know what a patient's course is. Here is a patient in New York Heart Association 3A stable where they're too well for an LVAD. Here they're about to die, they're too sick for an LVAD. And somewhere in this optimal range, you have to decide to go ahead and put in the device. And you can have patients with cardiogenic shock come in with an MI or suddenly deteriorate. Most of our patients are in this area where you don't know when they're going to take this dive down, but you expect it. The thing that's really scary are these patients, and these are primarily young patients. We've had several patients now 18 to 25 who have cardiomyopathy and they're stable and they look good and feel good, and then suddenly they just crash. And I think that's because when you're young, you have such well-developed and functioning systems to keep you stable. Their ability to accommodate a low cardiac output is so good that they go right up to the edge of shock looking good, and then suddenly they just go into shock. So these patients can be very scary, and our young patients we have to watch very carefully. Most of the patients follow this kind of path. So I'm going to switch gears now and talk about some more practical, everyday issues of heart failure that you can take advantage of. First, I'm going to talk about aldosterone antagonists. This is a study, TOPCAT, that just came out this year, looking at patients with HFpEF, which stands for heart failure with preserved ejection fraction, or, quote, diastolic dysfunction, heart failure with normal ejection fraction, which is about 50% of the patients that usually are admitted to the hospital. And everything we've studied in those patients has not shown to be of any long benefit other than diuretics. I mean, we know we have to diurese these patients, control their blood pressure. But, you know, use of ACE inhibitors, ARBs, beta blockers, calcium blockers, nothing has really been shown over placebo to have a significant impact on these patients. So this study looked at aldosterone antagonists in HFpEF. And again, primary endpoint, there was no difference. But in hospitalizations, there was a statistically significant improvement in hospitalization in these patients with the use of aldosterone antagonists. So something to think about. So based on this, I'm going to start putting all my HFpEF patients on aldosterone antagonists. Obviously, you have to watch their potassium carefully. That's the downside, that some of these patients will get hyperkalemic. The emphasis trial also used aldosterone antagonists in heart failure. This time it was in HFrEF, or heart failure with reduced ejection fraction. And these were patients with class 2 with ejection fractions below 30%. Now, the current or the previous guidelines for the use of aldosterone antagonists in heart failure was they were restricted to class 3 and 4. So if you had a class 3 and 4 heart failure patient, adding aldosterone was shown to improve their survival. So this looked at class 2 patients, moving aldosterone antagonists earlier, and this was strongly positive with p-values that were very high. Primary endpoint was death or heart failure hospitalization, and then all-cause mortality. So adding aldosterone antagonists even to class 2 patients with reduced ejection fraction can improve their survival, and adding it to patients with normal ejection fraction can reduce their hospitalization. So a larger use of aldosterone antagonists, I think, can be advocated for. Digoxin. You know, we practically stopped using digoxin for many years in heart failure unless the patient was in atrial fib. But in this study that was just published last year, looked at patients with heart failure, systolic and diastolic, with over the age of 65, giving them digoxin or placebo, and there was a very good, statistically positive improvement in hospitalization. So we know digoxin from previous studies doesn't improve survival, but it does seem to improve symptoms, and in this study prevented hospitalization. So again, if we're focused on preventing hospitalization, using digoxin and aldosterone antagonists in these patients would seem to be a good strategy. How about diuresing these patients? The DOSE trial looked at various methods of using diuretics in volume-overloaded heart failure patients. First strategy they used was a bolus dose versus continuous infusion. Patients received furosemide every 12 hours as a bolus dose versus the same dose given continuously as an IV infusion. And there was absolutely no difference in urine output, which was a surprise, but that's why we have to do these studies to find out what works. And so Q12-hour bolus infusions seemed to be just fine. And then they also used a high dose versus low dose strategy. So the low dose strategy was given their same oral dose intravenously when they came in the hospital. So if they were on Lasix 80 a day at home, they would get 40 BID IV in the hospital. Versus high dose, where you gave them 2.5 times their oral dose in the hospital as an intravenous bolus. And so that did show an improvement. So high dose diuretics did win out over low dose diuretics, whether it was given as a bolus or constant infusion. However, there was more rise in BUN and creatinine in the high dose group. So I think the message here is we should be comfortable giving pretty big doses of diuretics to these patients on a Q12-hour schedule. Now, what about aquapheresis? Do you use aquapheresis here? Mechanical removal of fluid with slow ultrafiltration. Well, aquapheresis or scuff has been quite popular in places that see a lot of heart failure, and it's simply a way of ultrafiltrating patients in a very simple way that can be done on the floor by floor nurses. And so these aquapheresis devices were very simple to hook up, and it would remove anywhere from 100 to 300 cc's of isotonic fluid per hour using a filter, and it worked pretty well. And you could take an awful lot of fluid out of these patients and not give them any diuretics. You let their kidneys rest. So the strategy was you rest the kidneys, remove fluid mechanically, and then when you put them back on diuretics when they go home, now their diuretic resistance has resolved and they respond much better to diuretics. So it was theoretically quite nice. And the thing about this technique is it removes tons of salt. You're taking isotonic fluid out of these patients. So 140 milliequivalents per liter of fluid, of salt you're removing per liter of fluid. Whereas if you give someone Lasix, they pee out a hypotonic urine, so you're putting out a lot of urine but not much salt. So you're taking a ton of salt out of these patients with this technique. But all-cause mortality was no different. In fact, it was slightly higher in the scuff patients, and there was no difference in any of the other outcomes. And so this looked like a technology that wasn't helpful. And keep in mind, it removed a lot of salt, which we think should be the right thing to do in heart failure. So just when you think you understand heart failure, you see a study like this. Intravenous salt supplementation with low-dose furosemide for treatment of acute decompensated heart failure. And what these investigators did was they took heart failure patients, gave them 500 cc's of hypertonic saline, 1.7% hypertonic saline, plus 40 milligrams of furosemide, and infused that over 24 hours, and compared it to a group with D5W and 40 milligrams of furosemide over 24 hours. And the saline group won. I mean, the saline group put out more urine, had more weight loss, had an increase in their glomerular filtration rate, and a decrease in their pro-BNP over the group that was just getting D5W and Lasix. So much we need to understand about even the simple decongestion of heart failure patients. This reminds me of potentially the beta blocker story. We're told beta blockers are bad in heart failure, and then we learn that they're extremely important in heart failure. And maybe Saline is going to be the same way. The beneficial effects of hypertonic saline on renal function may actually benefit patients who are salt and water overloaded. So even at this late stage of the game, we have so much to learn about how to treat these sick patients. Now, I want to tell you finally about the Paradigm trial, which we were part of in Des Moines. 8,000 patients were randomized to a new drug, doesn't even have a name yet, LCZ696. 200 milligrams of this drug versus enalapril, 10 milligrams BID, in heart failure patients with ejection fraction below 35%. Now this drug is a new class of drugs called ARNIs, angiotensin receptor neprilysin inhibitor. In this case, in this molecule, the receptor blocker was valsartan, and it's equivalent to about 160 milligrams. So in this trial, you're giving patients 160 milligrams of valsartan BID with the neprilysin inhibitor component. Now, neprilysin is an enzyme in our bodies that degrades natriuretic peptides. So if you inhibit neprilysin, your natriuretic peptides, ANP, BNP, various others, go way up. And these natriuretic peptides, remember, cause vasodilatation, cause salt and water excretion, which is what we want in heart failure. Now, for some reason, in heart failure, even though your BNP goes way up, it doesn't work. But this neprilysin inhibition seems to restore the functional capacity of these natriuretic peptides. And the fascinating thing is this study was just stopped for benefit. Now, I can't remember the last time a data and safety monitoring board called me and said, we're stopping your study because the patients are doing so well. I mean, it's usually the other way around. We're stopping the study because drug doesn't work and the patients are not doing well. So this is very promising, and I know that the patients that we had on this, of course I don't know if they were on enalapril or the new drug, but they did well, and I could almost tell who was on the new drug because their pressures were so low. The effect of the BNP elevation makes blood pressures drop, so these patients were walking around with blood pressures in the 90s, but they felt great and they did well. So we haven't seen any statistics from the trial. I can't tell you any more about it, but the fact that they stopped it early is very promising, and I think this is a class of medicine you'll be hearing a lot more about angiotensin receptor neprilysin inhibitors. So finally, I want to end by talking about palliative care. If your hospital has a high mortality and a high readmission rate, you need better palliative care infrastructure. We have become suddenly aware of this at Mercy in Des Moines. And this has flown below my radar, I know. Cardiologists are slow adopters of palliative care. We have this mentality, we can always put in another stent, fix the valve, add an inotrope, put in a VAD. We can do something to keep the patient alive a little longer. And so we don't think of palliative care. But again, if we keep in mind that when a patient hits stage D heart failure, their mortality is extremely high, and a very small number of them are candidates for VAD or transplant. And so we should be talking to them about palliative care, end-of-life issues. And if we don't, we patch them up, they go home. They come back, we patch them up, they go home. They come back, we patch them up, and they die. And so our readmission rate's high and our mortality rate's high. And in fact, that's what we're seeing. In our hospital, we're seeing our readmission rate is below the trend line that gets you a ding, but just barely below. And our mortality rate's creeping up. And so when we look at our mortality rate, it's, you know, we're doing everything right. Everyone's on an ACE inhibitor, a beta blocker. We're doing all the things you're supposed to do, but our mortality rate's creeping up. And I think it's because we don't have a well-developed palliative care hospice program for heart patients. And so we're trying to catch up and get that in place. I think most patients would prefer to be supported and die at home rather than go through this cycle of readmission, 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 and then die in the hospital. If they get the choice, and we don't give them the choice because we don't have that discussion with them as we should. So we're trying to get caught up with that. So that's the end of my discussion, and I'll take any questions. Yeah.
Could you tell us a little bit more about the cost of the left ventricular assistive device? And the reason that I ask is not only what's the cost of the device, but what's the total cost like for a year's period of time? As you probably know, the DRGs for Mary Greeley here for a defibrillator actually don't even add up to the cost of the machine, let alone all the people that are involved with their care. So if the DRGs are less, if the payment is less than the cost of the device, does the hospital donate all that to these patients?
Yeah, it's extremely expensive. It's, you know, I don't even know what the actual cost of the device is, but to provide a patient with one of these devices, it costed probably at least $500,000. And we're going to have to watch that very carefully. We're going to have to learn all the tricks of billing, especially in a state like Iowa where our reimbursement is so low. And time will tell if we can sustain this over time. But by the numbers I showed you, our state is underserved right now in this technology. And hopefully we'll figure out how to finance it, or we'll just have to stop doing it. But we may have a rude awakening that it's something we just can't afford to do. But until you do it and learn the tricks of billing, you don't know for sure. We're working closely with the university. In fact, every Friday we have a joint heart failure conference with the University of Iowa, and we present patients to them, they present patients to us, and we discuss the potential costs and insurance issues. And so far, they've been able to make a go of it, but they've got unique funding. So we'll see if it can be done in a private hospital.
Could you have a pump for the right heart also?
Yes. But it's not something that you can get up and walk around with. So if a patient is acutely failing, we can put in an RVAD just as an LVAD, but that means the patient's stuck in the hospital, usually in bed. And so that's done temporarily. And sometimes when we put an LVAD in, the right ventricular fails, we have to mechanically support the right ventricle for a while. And then the hope is that it will recover, we can get the RVAD out and send them home with an LVAD. There's also a total artificial heart, but again, that is not something you can go home with.
I was wondering, in your experience, what % of these LVAD patients are able to actually get home as opposed to continued hospitalization or skilled stays? All
of them. That's the goal. I mean, if we put in an LVAD, the goal is for them to go home, and if we don't think they can go home, we don't put it in. So this is a device that's considered durable mechanical support that will allow patients to go home and live, you know, close to normal lives. And frankly, they do. We've got patients that, you know, travel to Florida for the winter, paint their house, play golf. You know, their functional capacity is normal. They have to just be careful not to hook their drive lines on something as they walk by and things like that, just practical issues. But their ability to exercise and function is normal.
Was that digoxin study with decreasing hospitalizations, was that preserved EF as well as normal?
Yeah.
Okay.
Yep. Yeah, digoxin is we think of it as an inotropic drug, but it's also sympatholytic. And so in patients who can't take beta blockers for some reason and get the there's some patholytic effect from beta blockers, digoxin may benefit that group particularly, although this study didn't address that. But in all comers, it did show a reduction in hospitalization, and in my mind, it might be especially valuable in patients who can't take beta blockers for some reason. Okay, well, thank you very much.